Good morning, everyone, and good evening or afternoon where you are in the world. I'm Amy Freeman Sanderson, and I'm delighted to be able to be a co-moderator of our first 2023 GTC webinar. We've got our topic today is Tracheostomy 101 Fundamentals from Insertion to Decannulation and Beyond. I'd like to begin with an acknowledgement of country. And I would like to acknowledge the traditional custodians on the land and the lands in which we all meet today, and pay my respect to the elders, both past, present, and emerging, acknowledging them as the traditional custodians of knowledge for this land. I can see we've got quite a few people from across the globe joining us. So thank you for popping into the chat where some people are joining us from. So today in our hour-long webinar, which includes a Q&A panel at the end, we're going to be covering a couple of objectives. We're going to be understanding the fundamentals of tracheostomy insertion and placement, recognizing different team member roles and the different parts they play in a tracheostomy journey, looking at different types of tubes and components. We're going to also be exploring and talking about the complexities of the different tracheostomy pathways that we might work with our patients and our families along their journey. And also we're going to be touching on the lived experience of having a long-term tracheostomy. So I'm delighted to cover these objectives. We're very fortunate to have a stellar panel of 5 experts from multiple disciplines. All of these professionals are from Austin Health and from the TRAMS team. So we'll go into more of an in-depth introduction to them all before their path, but we've got Prue Gregson, Associate Professor Stephen Warillo, Lucy Bonacda, Christine Bunn, and Hannah Visby. So welcome, and I'll hand over to my co-moderator, Michael.
Sure, well, it's a pleasure to be here, and it's really exciting to see just such a robust presence here from all over the world. By way of introduction, Prue is the manager of the Tracheostomy Review and Management Service and is a truly remarkable leader who is sharing her work related to patient-centered tracheostomy care. She's really bringing the work in Austin to new heights. The tremendous turnout at this session, I'm sure, is a reflection of the position of Austin Health as thought leaders in this area. Prue is a senior speech pathologist at Austin Health, and our interests include holistic tracheostomy care and communication options in ventilated patients with a tracheostomy. Prue is particularly passionate about ensuring equitable access and delivery of quality healthcare for everyone living with a tracheostomy, particularly those in the community. Thanks, Prue, for joining us.
Thank you so much, Michael, and thank you, Amy. I'd just like to begin by expressing our gratitude to be able to present here today amongst such a wonderful community from around the world. It's a real honour, and TRAMS is very happy to be here, so thank you. My position here in presenting is very brief, simply to set the context of the content which you'll hear today. So we, Austin Health, are based in Melbourne, Australia, so down under, down south, keep going down. We're a large tertiary public health facility that goes across 3 campuses, acute services, subacute services, and we also have mental health units. So we have about 800 plus overnight beds. Our numbers from 2022, we had about 90,000 ED attendances and over 110,000 inpatient admissions. So we're a decent size organisation. We do have many specialty services that are statewide. I won't go through them all, but some of them that we work very closely with are our colleagues in the Victorian Respiratory Support Service, or VRSS, and the Victorian Spinal Cord Service, as well as our liver transplant service. So here at Austin Health, tracheostomy is a very commonplace. We see about over 200 trachees per year, a really broad case mix. So anywhere from medical to surgical, respiratory, neuromusc, neurological, spinal. So it's ENT, max vax, a large extension of patients that we see. So that's a little bit of context for you. For those who may be unfamiliar, TRAMS, or the Tracheostomy Review Management Service, is a consultative interdisciplinary team. So we provide care and management of patients with a tracheostomy outside of the ICU through to subacute and into the community. A big part of our role, which you'll hear about, is education, teaching and training. We organise and coordinate policies and procedures and provide governance in terms of tracheostomy care. We're a very highly structured team that consists of respiratory physicians, clinical nurse consultants, physiotherapists and speech pathologists, and we collaborate broadly with all of our specialty teams who see tracheostomies across the organisation. We're very proud to be the Australasian lead site with the GTC and really recognise the power of collaboration and working together. And over the years, it's been a real pleasure to be able to connect with so many around the globe in improving tracheostomy care. Very briefly, we do have an external website where all of our resources are available. We have some new e-learning modules which will be up there shortly. All of our policies, procedures, guidelines are up there. So please take a look, and if you do have any questions following this webinar, please get in touch. We'd love to hear from you. And finally, something to consider as we go through today. There's huge amounts of content to cover. We certainly just scratched the surface. So thinking about this patient population, we're predominantly responding to adult patients. So much of this is transferable though to the paediatric population. This is a very vulnerable, complex, high-risk patient group. So we're thinking about tracheostomy care across this continuum and acknowledging the change in care needs as a patient moves from ICU onto the wards and out into the community, the right care at the right time. So I won't hold the floor anymore. I'd like to pass back to Michael and thank my team very much for their contribution today.
Well, thanks, Prue, for that wonderful introduction. So our next speaker is Professor Stephen Warlow. He is an intensive care physician who's been a leader in critical care and with the Global Tracheostomy Collaborative since its inception just a little bit more than a decade ago. Stephen has served in too many leadership roles to count, but prominent among them are serving as past president of the Australian and New Zealand Intensive Care Society. And in 2019, he convened the World Congress of Intensive Care, which was hosted in Melbourne. He currently serves as director of the Department of Intensive Care at Austin Health in Melbourne, Australia, and is the divisional director of medical services. His private practice is based at Epworth Healthcare, where he is director of the Critical Care Institute. He also has an academic appointment with the University of Melbourne. Steve provided critical leadership during the COVID-19 pandemic. During the COVID response in 2020, he became a lead of the critical care response for the Northeast Cluster and chaired the Victorian State ICU Directors Forum. His professional interests are diverse. They include critical care outcomes, clinical governance, end-of-life care, clinical teaching, and complex communication. He has over 100 publications and is an award-winning writer for several amateur radio magazines. He's a winner, actually, of the Amateur Radio National Field Day competition, and he'll be covering practical aspects of timing and technique. We're delighted to have you, Steve.
Thank you for that excessively generous introduction, Michael. That's very, very kind of you. It's rather humbling to be on this panel of really senior experts in their field, and I'm very grateful for the opportunity to share with you today the perspective of an intensivist. To point out that this is a perspective that is predominantly adults from my practice, and also critical care based, and I recognise that this is one important but small facet of the full breadth of tracheostomy practice. Hannah, if you could advance the slide. So let's briefly recap the indications for tracheostomy, and just to remind people that the slides and this recording will be available later and references as well, because we will need to move reasonably briskly through. In the ICU perspective, we insert tracheostomies for patients we anticipate having prolonged mechanical ventilation, but also to facilitate weaning when we're in that mode of care. And it certainly allows us to reduce sedation, which provides a huge range of benefits for our patient population. We can maintain airway protection. On some occasions, it's to have a workaround an upper airway obstruction. And rarely we would also use it in an emergency scenario for a failed intubation. And there are occasions also when a patient can breathe rather well for us in ICU, but has significant problems with pulmonary secretions, and a tracheostomy can assist in the care of that patient as well. I'm often asked by my trainees and nurses why not just keep the endotracheal tube in, and sometimes that is a reasonable option. However, we know that prolonged translaryngeal intubation can put some patients at risk of a laryngeal injury. To be fair, that's less common with our modern types of tubes, but nonetheless, it is a real risk, and one that should concern us. And there is some suggestion that early tracheostomy might minimise this risk of laryngeal injury, which is a great thing. I think just as importantly, though, it really allows the rest of the care to be significantly enhanced. We can frequently remove all requirements for sedation, which is profoundly useful as we're trying to start to rehabilitate our critically ill patients. And for the rest of their care, as we'll cover shortly, it's just so much easier. And for those of us involved in weaning from mechanical ventilation, it's so much straightforward and safer in a patient who has a tracheostomy compared to trying to do so when it's really difficult for a patient who continues to have a translaryngeal tube. So some of the other benefits to recap: it certainly facilitates some effective secretion management and airway care. We find our very supportive speech therapists can make communication so much more straightforward for these patients as well. Patients feel a great deal more comfortable. And I think it's easy sometimes as clinicians to underestimate the huge benefits that of a psychological nature. The patients feel and can see that they're making progress, as can their families. Perhaps a minor issue, but people look a whole lot better when the tube's out of their mouth. The number of families have said, I can now say I've got my loved one back. They look like themselves. I guess we shouldn't focus too much on the cosmetics, but as part of the overall package of care, people really feel psychologically that their progress is advancing considerably. As I've already touched upon, it's so much easier to wean patients with a tracheostomy. Trials of spontaneous breathing are very straightforward, and our nursing staff can facilitate that really fairly independently, with us as the medical team outlining a range of goals and an overall plan. And then the nurses and the physiotherapists in particular will get on with it. And that's a tremendous advantage for patients that really facilitates, I think, an acceleration of their progress. We can change tubes very readily once the trach is mature, if that becomes necessary. And we often find that we can more readily get patients out of our ICU and into a general ward, partly because they've got a tracheostomy, but I should emphasise that's with the tremendous support of our trans colleagues. And so to do this really requires the strength of a multidisciplinary team who are very experienced in managing that transition and ongoing care. There's a lot of debate, and I'm not sure it's going to end in a hurry, about the timing of tracheostomy. And there's certainly been guidelines in the past that if you're going to need mechanical ventilation for 10 days or less, just stick it in the endotracheal tube. And if you're going to be ventilated for more than 3 weeks, then a tracheostomy is a good idea. And there's not a vast amount of robust evidence to guide us. And I think our practice has come to reflect that this is really a very individualized consideration for the patient that you're actually caring for at the time, and to be guided by expert opinion and experience, and try and tailor the approach for the patient. Certainly when a longer period of mechanical ventilation is anticipated, then modern techniques of tracheostomy insertion are very safe, very well tolerated, with very few risks to a patient. And I think for many patients, the balance of risks favours early tracheostomy under many circumstances. And there is some evidence that there may be benefit in tending towards an earlier tracheostomy. but certainly in medical patients that you can reduce length of stay, and indeed it's got some financial benefits for the community if we do that. In trauma patients, similarly, and also in head injured patients and those who've incurred burns. So there is some evidence base to guide us. Generally, our practice is that between 10 and 14 days, if we can see a patient will require ongoing ventilatory support, then we're certainly thinking very carefully about proceeding to tracheostomy. I won't go into huge detail about insertion techniques because many of you will be familiar with them. I think there's some benefits for both surgical and percutaneous, but both require anesthesia, both require specialist training and also trained assistants. Surgical tracheostomies can be undertaken by a wide array of surgical experts, and there's no real patient that wouldn't be appropriate for a surgical tracheostomy. In many organisations, it requires moving to the operating room, which can bring logistical problems and a need to assemble a team. But some organisations can do them at the bedside, certainly in the ICU. And at the Austin here, we will do surgical tracheostomies pretty regularly in our ICU. The surgeon will come to us. There are some patients, however, just go to the next slide, Hannah, in which surgical tracheostomy is the only option. And I don't think any clinician would suggest that a percutaneous approach would be suitable for the patient pictured here. With percutaneous tracheostomies, they can be undertaken by anaesthetists and intensivists. They're almost always done at the bedside. It has benefits that we don't necessarily need to take a patient to the ICU, to the operating room, particularly when they're unwell. And we can maybe be more selective with the timing because we're not having to coordinate with operating room teams. There's few absolute contraindications. And really, in my experience and when I speak to colleagues, the case selection is largely based on the clinician's comfort, experience, and their preferences and what support might be available from surgeons in their organisation. And there's several methods described. Probably the Charlier dilatational technique would be the most common one around the world, but there are others as well. Complications are pretty rare in experienced hands, and the rate is similar regardless of the insertion technique. There might be less inflammation and infection with the percutaneous approach, but I think it's a relatively modest benefit. There might be fewer technical difficulties with surgical technique, but I think these are relatively minor considerations. My colleagues who are involved with decannulation on the ward tell me that the stomach can close rather more quickly with the percutaneous technique, so that might be something to be aware of and provide a shorter time frame for successful reinsertion if the patient fails decannulation. So maybe something to consider at that point. In terms of complications, whilst they're rare, they're important to consider, and I've listed them there. I won't go into huge detail. You can read those for yourselves. We'll move to the next slide, Hannah. Late complications, again, these will be well known to many participating in this forum. I think the one I impress most upon my trainees and colleagues is tracheonominate arterial fistulas. I think it's behoven on any clinician involved in tracheostomy care to take bleeding very seriously. I think those of us who've seen a tracheonominate fistula bleed, once seen, never forgotten. I think we'd all agree better to be very aware of it and to investigate early, often with angiography. I think CT angiography provides us with a really useful tool these days to ascertain what might be going on, and to urgently escalate to the proceduralist, be they the intensivist or the surgeon who inserted the tube, to participate in the investigation and also the ongoing management. We've got some guidelines which will be available through our websites on how we approach management of these problems, and we divide into sort of early and late bleeding approach. Those resources are available for you to look at, but I would certainly urge everyone to have their own approach to dealing with these issues, because they have a tendency to happen after hours, and often when the most senior people aren't on site. And you can see there an example of some of the resources that we've developed to teach, train and support our colleagues, particularly on wards, and also those who may be less experienced, so that they can follow a very linear algorithm to approach these problems often under pretty high pressure situations, so that we minimize variation in practice. We have a strong emphasis on escalation and to focus on the fundamentals of supporting the patient whilst simultaneously dealing with the issues. Leaving the ICU with a tracheostomy is a really important transition, and I feel enormously grateful for the presence of a comprehensive service here at the Austin. Without it, I think as an intensivist, I would feel pretty anxious about one of my patients with a tracheostomy, that we've often invested weeks and months in getting them through a critical illness to the ward. And it's a tremendous opportunity to graduate from the ICU to the ward with a tracheostomy safely, but that does require a comprehensive multidisciplinary team to do it well. These patients, by the nature of their circumstances, will be complicated, and their airway issues and respiratory issues will be but one key facet of a multitude of issues that also need to be supported. I think, as you'll hear emphasised, it's the multidisciplinary nature that has been a huge contributor to our success, and having high-level experts from different disciplines that work so well together. I think patients generally benefit hugely, and I have had patients, relatives say, I knew that my loved one would be fine when I saw how you interacted with each other. And that's, to me, the strongest testament of what we're delivering. I won't go through all the references there. Suffice to say they're available to you, and I'd certainly recommend reading any of the resources provided, and to take a look at our website, as already been mentioned by Prue. It's a huge library of opportunities to learn from, and thank you for the opportunity to share today.
Well, thanks so much, Steve, for an absolutely phenomenal overview. That was incredibly instructive. I think we all learned a lot from it. In addition, I wanted to call out just a couple of things that you emphasized. One is that shift of risk and benefit towards earlier tracheostomy, which is partially a reflection of advances in technique, also very much, and perhaps even more so, a product of the advances in how we approach multidisciplinary care. That's really a tribute to the outstanding people like those that we have as panelists. So my next guest is Lucy Banakdar. She is a senior speech pathologist working in the TRAMS team and has a master's degree in applied positive psychology. She's particularly interested in facilitating health and well-being in those living with the tracheostomy. Lucy is one of my favorite people because she's not only a phenomenal speech language pathologist, but she really adds to the human dimension of care. She has an incredible way with people and with patients. And that sort of dynamism in the approach to care really improves and benefits all of our patients. So Lucy, it's a pleasure to have you.
Thank you, Michael. That's very kind of you. I'm absolutely thrilled to be able to join you all today for this session. And in this next section, we'll be focusing on the role of the multidisciplinary team, as well as tracheostomy tube types and features of the tubes and communication options. There's increasing evidence that coordinated multidisciplinary tracheostomy teams support the safety and quality of care provided to patients and their family members. Teams can result in increased access to relevant expertise, and that can lead to earlier and increased speaking valve use, reduced time to decannulation, as well as reductions in length of stay. Each member of the multidisciplinary team has unique skills that they bring, whether it be in maintenance of a patent airway, tube choice, assessment and management of communication and swallowing, and decannulation decisions. Patients, families, and carers are certainly central within this team. We'll now look at tracheostomy tubes and communication. So we can see the key features of a tracheostomy tube here. It's positioned below the level of the vocal folds. This tube has a cuff with a corresponding pilot balloon, which allows the cuff to be inflated and deflated. We can see here the shaft, the hub of the tube or the opening, and the flange, which allows the tube to be anchored to the neck. There's a whole variety of tracheostomy tubes available. And in this slide, I'll draw your attention to just several tubes that we tend to use quite frequently at Austin Health. The Portex Blue Line Ultra Suction Aid tube is one that we tend to use frequently. It does have an additional line coming off it, which allows for aspirated secretions that pool above the cuff to be cleared without necessarily needing to deflate the cuff. It also does allow for above cuff voicing to be used, whereby medical air is gradually introduced to the above cuff area, to the larynx and vocal folds via the suction aid line, allowing a flow of air to produce voice. So cuff can remain inflated for this type of speech. Another tube to be aware of is the Bivona tight to shaft tube, which is made out of silicone, which makes it a bit softer, more flexible and more comfortable for patients. This has a water-filled cuff, and you can see that in this picture the cuff is deflated and it's very streamlined and tightly fitted to the shaft, which means that there's more space for the air to flow around the tube. And this has wonderful benefits for people using a speaking valve. Another tube to be aware of is the Portex Uniperk Adjustable Flange tube, which is used for people that have large neck anatomy, whether it be due to obesity or goiter, and gives additional length to secure an airway. The inner cannulas are tubes that fit directly within the shaft of the tracheostomy tube and provides an option for managing potential tube blockages. It's much easier in the sense that we can simply remove the inner cannula and replace it with a clean one. So there's a range of implications that are associated with a tracheostomy tube that is malpositioned or a tube that is too big or too small. This can have significant impacts on communication and as a result of that, psychological well-being. Additionally, it can impact on weaning from the ventilator, can cause trauma, discomfort and irritability for the patient. So where we're suspecting that a tube may be malpositioned or suboptimal for a patient, a tracheoscope or a CT can be useful investigations to visualise how the tube shaft is sitting within the trachea, whether there's any contact with the tracheal walls or how far the distal end of the tube is from the carina. Where there are issues with tubes when the cuff is deflated more so than when the cuff is inflated, it can be useful to scope the tube under both of these conditions. And where we do have an issue with the tube, we can consider downsize or an alternative tracheostomy tube type, considering the patient's anatomy and the tube measurements and dimensions, and choosing the most suitable tube from there. Communication is central in tracheostomy management, and it is a basic human right. It is essential for safe and good quality healthcare. There's increasing evidence showing the importance of communication in maintaining mental health and well-being when we have a tracheostomy. So we'll move now to hear from Brett about how he felt when he didn't have his voice when he was ventilated.
Can you just describe for me what it was like when you first could not communicate, and then what it was like once it was easier?
Oh, look, it was very much harder to not be able to tell people about your care and stuff that you need and want. Frustration was a big part of it. Trying to communicate to nurses and all the rest of it. But yeah, learning to talk was feeling like having half your life back, really. So
fantastic.
And as we move to consider the various communication options that are available for people who have a tracheostomy, we'll briefly recap airflow with cuff inflated and deflated as this influences what options might be most suitable. With the cuff inflated, we see that air is moving in and out of the tube. And when the cuff is deflated, air is moving in and out of the tube, but is also moving through the upper airway through the vocal folds. And if we were to digitally occlude or cover the tube with a finger or use a speaking valve, we would have the opportunity to voice. This Passimua valve or speaking valve is a one-way valve that opens when someone breathes in and closes when someone breathes out. Therefore, cuff needs to be fully deflated when a valve is used so that the person can breathe out. With airflow restored to the upper airway, the person has the opportunity to voice, improve pressures for cough, improve taste and smell, as well as improve sensation and pressures for swallowing. Using a valve is an important part of the decannulation process, which Hannah will be talking about more later in this session. Aside from speaking valves, there is a whole range of verbal speech methods that people with a tracheostomy might like to consider. Whether the person can manage cuff deflation or whether the person requires invasive ventilation influence what verbal speech method might be most suitable. So where people need to have the cuff inflated, then above cuff voicing that we spoke about earlier could be the best option. Where we can tolerate cuff deflation and are able to breathe spontaneously, the speaking valve or digital occlusion could be used. Where the person requires invasive ventilation but can manage some periods of cuff deflation, the multidisciplinary team might consider ventilator-adjusted leak speech or placing a one-way valve in line with the ventilator. We saw an example of ventilator-adjusted leak speech with Brett just before, and these approaches require creating a leak in the ventilator circuit to allow air to flow through the upper airway, through the vocal folds, and allow for voice. And as a result, frequently ventilator setting adjustments are required. These speech approaches are not without risk, so a high level of multidisciplinary coordination and expertise is required. If people aren't able to use those verbal speech options, other speech strategies would be considered, such as an electrolarynx or non-verbal speech options like communication boards, tablet and smartphone apps. Setting people up to successfully communicate with a tracheostomy requires a collaborative multidisciplinary approach and teamwork between clinicians, the patients, and their families. Considerations include, are there any contraindications or risks associated? How are we going to troubleshoot any problems or issues that arise? But perhaps most important is, what education training do patients and staff require? Tracheostomy pathways facilitate this area of management through increased coordination, collaboration, and education. And in this next section, Christine will discuss tracheostomy pathways in further detail.
Well, thanks. That was absolutely fantastic, Lucy. One aspect that really resonated from your talk was the quote from the United Nations, observing that communication is a basic human right. And it speaks volumes how you made a point to include the patient's voice, balanced with a wealth of detailed and practical information. I also love the graphics and the cognitive aids that you have at Austin. I actually just sent that same cognitive aid that Steve presented to some colleagues at Harvard that were looking for a resource on emergencies. So now I'm thrilled to introduce our next speaker, Christine Bunn. Christine is a clinical nurse consultant working with TRAMS with a graduate certificate in acute care nursing. Christine also works as an associate nurse unit manager with the Victorian Spinal Cord Service. She has a particular interest in collaborative and holistic care for patients with a tracheostomy, particularly those with complex and acute care needs. Christine, we're delighted to hear more about acute care pathways.
Thanks, Michael. So we'll talk a little bit about the tracheostomy pathways now. So it's clear that there's an increasing recognition for the need for a very coordinated and systematic approach within tracheostomy care. Throughout the presentation that I do, we'll briefly explore some of these concepts, including the standardization of care protocols for best practice, interdisciplinary education, multidisciplinary cooperation, and patient and family engagement. Literature describes the aims of tracheostomy care pathway being to improve tracheostomy education, standardise care, and enhance outcomes by closing the gaps in tracheostomy knowledge for staff and patients and families and caregivers, whilst also promoting interprofessional collaboration. So you can see in this diagram the complexities of a multifaceted tracheostomy pathway. Patients with a tracheostomy comprise a very high-risk patient group. We know that they may be cared for in a number of situations, whether that be in the ICU, on a multitude of wards, or within the community. The need for specialist interdisciplinary care to manage this population is very well documented. Here at Austin Health, we understand that partnering with the patients, families, and carers at the centre of this system is absolutely crucial to its success and ensures that they're involved in our service planning, as well as ensuring that they're involved in reviews and our quality improvement initiatives. We'll explore a few of these elements in some more detail. So moving on to governance and education with a look at quality, safety, and risk management. Policies, procedures, and a very consistent mechanism of care are absolutely essential to ensuring quality and safety for this patient group. Trans work collaboratively with a number of disciplines, teams, units, and wards, all who are involved in tracheostomy care, and this is to maintain clear evidence-based policies and procedures. It facilitates a very safe and effective standardised approach to tracheostomy management. These standardised protocols optimise consistency in care, environment, equipment, and patient and provider expectations. These protocols govern our multifaceted tracheostomy pathway and inform the systematic and stepwise journey of care that Hannah will discuss shortly. Standardised processes and documentation are incredibly important. Standardised processes and documentation promote coordinated care, they increase our efficiency of care and improve outcomes, particularly in airway emergencies. An example of this that we have within Austin Health is the ICU discharge form for when a patient transitions to the ward. And this begins from tracheostomy insertion. So when a patient's discharged from our ICU with a tracheostomy, the form's completed. It ensures very clear, concise, and accessible documentation about the patient's tracheostomy, from insertion and tube details to complex or high-risk alerts, and also includes whether ICU consultant notification is required for planned decannulation. It really optimises that collaboration and continuity of care. Similarly, we've also got a standardised process that guides the pathway to decannulation. It includes pre-decannulation assessment, the decannulation process, and post-decannulation care, and what we would do in the event of a failed decannulation. All of this is clearly documented and is visible to all clinicians involved in the patient care, which is very important. The standardised processes and documentation are utilised by all of our disciplines here, and they're necessary to ensure a consistent approach and that care is patient-centred. They support clinical decision-making and provide clear plans for ongoing management, ensuring that multidisciplinary input is accessible. In terms of risk and data, the data collection and analysis of tracheostomy-related adverse events is absolutely critical in ensuring safety and quality of tracheostomy care. It informs quality improvement initiatives, informs clinical practice, and also helps us to provide targeted education. Austin Health use systems such as RiskMed and the GTC database to capture this data. Being able to use dashboards to show adverse events over time promotes visibility and allows organisational-wide accountability, with details focusing on the area of incidents, the type of incident, and the frequency of them. It allows tracking and guiding of interventions such as targeted and specific education. Effective governance ensures strategic policy frameworks are established and maintained within health services with appropriate oversight and regulation. Integrated meetings and effective communication with all healthcare teams and key stakeholders involved in tracheostomy management is absolutely vital in safe and high quality care. Within Austin Health, our government involves Austin Health Airway Committee, the Deteriorating Patient Committee, the Interdepartmental Tracheostomy Forum, and GTC collaboration. Trans is a member of the Austin Health Airway Committee, and we report all adverse events to the Deteriorating Patient Committee. We hold twice yearly interdepartmental tracheostomy forums, which were instituted with the objective to improve patient safety and to improve communication across all the departments and multiple disciplines involved in tracheostomy care here. At each forum, we review case presentations, policies and procedures, risk data, any education and equipment issues, and we discuss any complex cases. Trams chair this meeting with representation from key stakeholders and heads of department, including respiratory, thoracics, ICU, ENT, anaesthetics, plastics, MaxFax, and a multitude of disciplines from medical, nursing, physio and speech pathology, so very well represented. In addition to these local committees, Austin Health is honoured to be a founding member of the GTC. The GTC is such a wonderful community of healthcare professionals and teams, patients and families, collaborating to empower and inform transformative change and continuous improvement in the quality of care for patients with tracheostomies. The database facilitates collection of detailed patient-level data for each tracheostomy admission, and that allows us to analyse, report and benchmark outcomes. One of the key drivers that's been found to be critical bringing about major improvements in tracheostomy care is broad staff education, where all patient encounters involve healthcare staff who have been appropriately trained in tracheostomy care. These interventions have demonstrated a marked improvement in objective knowledge and confidence with providing tracheostomy care, which clearly translates into safer practice and care. Ongoing and coordinated tracheostomy education must be readily available for all patients, families, and staff. This requires a number of different education techniques, training, and continuing and ongoing education. It's recognised that systems with comprehensive training and technical skills, as well as organisational support structures, decrease morbidity and mortality. Here at Austin Health, we do utilise a combination of these. We have face-to-face education, in-services, workshops, training, study days. But more recently, we've developed some new e-learning modules and an interdisciplinary tracheostomy competency program that's for nurses, physiotherapists, and speech pathologists, as well as some new resources for patients, carers, and families that are living with a long-term tracheostomy in the community. We are incredibly excited to be able to share these with you in the near future. But it's very clear that multidisciplinary standardised care and ongoing education are absolutely essential to the whole tracheostomy pathway. And Hannah will now discuss this stepwise approach.
Thanks so much, Christine. That was just wonderful. You're kind of the envy, I think, at Austin Health of the rest of the world with having such wonderfully coordinated and choreographed care. And it's terrific to see how your organization has embraced the key drivers of the Global Tracheostomy Collaborative, and in many ways was an exemplar that helped us when we were defining those standards. So now we're going to transition to our final speaker. I'm thrilled to introduce Hannah Versby as our next speaker. She is a senior respiratory physiotherapist working with both TRAMS and the Victorian Respiratory Support Service, primarily in the ventilation weaning unit. She has a particular interest in the holistic management of patients weaning from mechanical ventilation, including the ventilated spinal cord injured patient. She specializes in assessing and training respiratory muscles, particularly in the prolonged mechanically ventilated patient. We're delighted to have you, Hannah.
Thank you. So today we're going to be talking about stepwise tracheostomy care. So the literature highlights the need for a systematic patient-centered approach to trachea care. There are institutional variations in practice that's guided by expert clinicians with the goal for a timely and safe removal of a tracheostomy. The evidence supports the use of the multidisciplinary coordinated approach to tracheostomy management and leading to a reduction in adverse events, length of stay, and decannulation. Here you can see just one example of a tracheostomy pathway that can standardise patient care across an organisation and reduce time to decannulation. As you can see, it's complex, it's multifaceted, but the approach results in positive patient outcomes. It's important to consider a systematic stepwise approach to tracheostomy care, highlighting three key elements of airway patency, protection, and airway clearance. The time a patient may spend on each of these steps will vary based on individual progression, team assessment, and a lot of troubleshooting along the way. Airway patency. the sound in the background. Airway patency. So a coordinated approach with our speech pathology colleagues can guide our decision making. As Lucy discussed earlier, the early identification of cuff down and PMV trials can facilitate assessment of airway patency, laryngeal function, and voice quality. It can also result in the early identification of vocal cord palsy or immobility, which can directly impact patency. If there are concerns around patency, evidence has shown that ENT evaluation to guide our decision-making is critical. Other considerations should be around the tracheostomy tube size. For example, the presence of a size 9 tube in a small lady or a small patient, or the positioning or the angle of a tracheostomy tube. In regards to airway protection, our speech pathologists can guide the assessment of a patient's swallow and their ability to manage secretions. The assessment of above cuff secretions can give an indication of protection. However, consider the presence of an inflated cuff does reduce swallow efficiency by reducing sensation, subglottic pressure, and motility. And this highlights the benefits of early identification of cuff down trials. There are a number of factors which can affect upper airway secretions, such as postnasal drip or tracheostomy-related hypersecretion. And a multidisciplinary approach to the management of these secretions can reduce aspiration risk and time to decannulation. When progressing towards decannulation, airway clearance is crucial. You need to consider a patient's cough. Do they have the respiratory muscle strength, the lung volume, and the glottic closure to create an effective cough? Sputum volume is an important factor, as large volume of sputum can result in increased fatigue over time and predispose the patients to respiratory failure. Clinicians can always consider other forms of airway clearance, such as a mechanical inexiflator, here in the picture, which could guide decannulation. Other things to consider when looking towards our stepwise approach to decannulation is, does the patient have any further surgeries planned that will impact decannulation timing? Or will the patient require non-invasive ventilation after decannulation, in which case you may consider trialing non-invasive ventilation and masks to set your patient up for success. Timing of tracheostomy decannulation is a dilemma, and it arises because there are consequences in too early and too late for timing. Too late can increase your risk of complications, including infection, and too early can increase the risk of respiratory failure. In some cases, it's not possible to decannulate our patients, which leads to the community patients living with a permanent tracheostomy. Here at Austin Health, there are 2 multidisciplinary services to assist those patients living in the community with a tracheostomy. There is the Victorian Respiratory Support Service, a statewide program for adults for patients living in the community with a tracheostomy and an invasive ventilator, and the TRAMS team that coordinate the non-ventilated tracheostomy patients in the community. So we truly value our patients and recognise the power in partnering with them. Their experiences help us identify gaps, address challenges, and achieve successful quality improvement initiatives. One of the ways we do this is through the Patient and Family Tracheostomy Forum that we run here at the Austin. And these forums provide a platform for the patients, families, and clinicians, with the focus being on their well-being of living in the community, including sharing stories, discussing challenges, and celebrating successes. We have a funded community program that's patient-centered and multidisciplinary. It comprises of education, training, equipment, and coordinated care to support our patients living in the community with a tracheostomy. Patients with a tracheostomy discharging to the community, along with their carers and families, have access to a range of resources that can provide them with the knowledge and skills to support them living safely in the community. This is just a snapshot of some of the resources available from the GTC and the Austin TRAMS website, so they have a lot of access. And at the centre of all of our work is our patients, their families, and their carers. We worked with Sylvia here and John to help fulfill her dream to travel around Australia. Sylvia is an inspiration and did not let her trachea tube hold her back. And here we'll hear from Sylvia.
Okay, tell us a bit about yourself.
Hi, I'm Sylvia, and I'm 52 years of age, and this is my husband, Tom. We love to travel around Australia and see everything that Australia has to offer.
And what has your experience of having a tracheostomy been like?
At first, it was a little bit scary. I remember when the surgeon was explaining the surgery to me. As soon as he said, we had to put a hole in your heart, I was very scared. But when I woke up and I knew the purpose of the trachea, I was much better.
Now tell us about your trip to Queensland in the caravan and what were some of the challenges and some of the highlights?
Yeah, and it wasn't difficult. My husband is very handy and he set up our caravan to be a hospital on wheels. And we had all the machines there. Everything that I needed was there. It had a couple of stops to the hospital, but otherwise it was easy, and we did it.
We just did what we could do.
That's right.
At the time, it was easy. It was still enjoyable.
Yes, absolutely.
Yeah, it was wonderful looking at some of the photos, some of the places you got to explore.
And that was beautiful.
Yeah. What advice would you have for others embarking on travel with a tracheostomy?
Good. Nothing, especially a trachea, it's not enough to hold you back. I did it. I had the support of the trachea tank, but also my husband, and he encouraged me to say, you can do this. I'm there. If you need my help, I'm there. And it was fine. The only thing I couldn't do was run. Okay.
No, couldn't do a lot of the longer walks.
That's right. But we managed and we had an awesome time. If I can do it, anyone can do it.
Well, thanks so much, Hannah. That was a wonderful talk, and especially appreciate your putting the family front and center. That was a wonderful way to cap off this session. So now we're going to go into the question and answer portion of our program. Thanks for all of you that have maintained your attention and posted various questions and thoughts and said hello from different parts of the world. But before we make that transition, I just wanted to mention an exciting event. Our 7th International Tracheostomy Symposium is going to be from October 20th to 21st. It's going to be at Johns Hopkins in Baltimore, and we hope that many of you will be able to join us there. So with that, I will hand it off to my co-host, Amy.
Thanks very much, Michael, and thank you so much to all the panelists for your contributions, and to Brett and Sylvia and John as well. I'm going to jump to one of the questions that's come up in the Q&A box, and this is going to be directed, perhaps to you, Lucy, to talk about a little bit more about ventilator-adjusted leak speech, and just a couple of any risks that could be associated with this.
Yes, thank you, Amy, and thanks for the questions. So ventilator-adjusted leak speech being one of our methods for verbal speech whilst on the ventilator, if the question is particularly around risks, we need to be thinking here about whether the patient is medically and hemodynamically stable, which can be an issue in some of our high spinal cord injury patients towards the early part of their admissions. And so here we're linking in closely with our medical colleagues and our multidisciplinary team. We need to be considering with this speech approach about adequate ventilation, loss of PEEP and lung de-recruitment. And so when we're working with this speech approach, we are, and Hannah can jump in here, we're working with our physio colleagues to make some ventilator setting adjustments to compensate for that leak, and also looking at control, laryngeal control, and modulating that airflow so that we don't have significant leak of air through the upper airway. Another risk to consideration is certainly aspiration, anytime we're deflating a cuff. So again, we're looking at swallowing function and assessing that. And sometimes there's a place for anticholinergics to support that too.
Thanks, Lucy. Did you have anything that you wanted to add to that, Hannah, in terms of the physio aspect of any risks or benefits?
As Lucy discussed, mainly with ventilated adjusted leak speech, our risk is aspiration, I guess, secretion volume and maintenance of that, and around ventilation. So our primary job as the physiotherapist in part of the team when we're assessing ventilated adjusted leak speech is to really ensure adequate ventilation for the patient to account for the leak in the system. So we can change our tidal volumes and our minute ventilation to support our patients, and also to see, can we consider other ways to progress the patient if there are upper airway secretions that are limiting ventilated adjusted leak speech. We feel it's a priority to be able to have our patients communicate, as Lucy showed in her slide. And so any way we can facilitate that, then we try and do it.
Thank you. And I think that really does highlight sort of looking at how you're managing risks and the benefits, and it's weighing up each person, the team, and what is right for that patient in the point of time. One thing that came through really strongly in fundamentals, so there was a lot of comprehensive detail around the tube insertion, the reasons, management, but safety was something that came up quite strongly through all of your talks. So I'm just going to jump to that in regards to safety and protocols with care. There's a couple of questions. One's in regards to, do you have any thoughts around or resources around risk assessments with single lumen tube versus double lumen tubes? And also the other aspect in regards to safety and care is in regards to skin integrity and looking at how we assess and manage that. So over to the panel, perhaps. Stephen, would you like to take that, or Prue? Yep.
Stephen, feel free to jump in. I was just going to comment on the single versus double. At Austin, historically, we did always have single lumen tubes on the background of our very strong policies and guidelines around humidification. And actually, after implementing the GTC database and collecting data over many years, we're able to go back and look at some of our events, adverse events that were happening, and some of them were around partial tube occlusion. And so we've actually instituted double lumen tubes as a policy now across all areas. However, there are patient-specific areas where it might be single lumen, particularly in those respiratory patients whose secretions are quite thin or very minimal and who need the wider lumen tube. So interestingly, our practice has changed over time. I don't know, Stephen, if you have anything to add to that.
No, I think that's a great response, Prue. And I think you can get away with single lumen tubes, but you do have to pay extraordinary attention to humidification, and the team needs to be well aware of the potential limitations. So I don't think it's a huge issue, but we did change our practice, recognising the evidence when we evaluated it.
Thank you. So, I mean, really, some of those aspects are how do you apply the fundamentals, and having the governance structure that Christine spoke about with pathways and data collection is a big part of how you apply and monitor tracheostomy care. In terms of, you know, those policies, how do you enable that as a team, or how would you, what would be your advice in terms of centres that you don't have, I guess, such a coordinated team? How could they move forward with the fundamentals with governance and safety?
I think a really big position to start with is recognising that tracheostomy care really crosses so many disciplines, units, areas, and that it's all people who are involved in tracheostomy care that really need to contribute to those policies. We do have an overarching policy at Austin Health regarding tracheostomy management, and we have all heads of department from ICU, thoracic surgery, ENT, MATVAX, anaesthetics, physio speech, clinical nursing, the whole gamut of individuals who are involved at that level. And these policies are endorsed by these units and disciplines. We also run, as Christine had mentioned, twice a year an interdepartmental tracheostomy forum where key stakeholders are involved in that meeting, and we discuss all of the issues that might arise or any changes in practice, and often have a case presentation to engage areas who might not ordinarily be involved in these discussions. So I think it's critical to ensure that whilst it might not be a core team that you have that's, you know, a funded service as such as trans, but really ensuring that you engage everybody who needs to be involved.
Thank you. And in terms of that engagement, was really reflected and strongly highlighted how pivotal the person with the tracheostomy and their family are to that process, to have input, to be involved in decision making as well. In terms of moving forward and really strengthening that that partnership and co-design in care, and how that success looks for a person with a tracheostomy, how could we move forward from here to really increase engagement? Any sort of highlights and tips from your team? So anyone that wants to take that one.
I can briefly talk, and Prue, you feel free to jump in at any time. But at the moment, in the last 12 to 18 months, as part of our education redesign package, we've been looking at partnering with our consumers, with our patients and the carers, to do specific videos and specific content that is just for them, targeted for them, not for the clinician. We have clinicians as well, and that's due to feedback from a lot of care agencies here in Melbourne and across Victoria that really are finding it difficult to access specific resources that they understand and that they can utilise. So a big part of our work in the last 12 months has been focusing on partnering with our patients to achieve that for them.
Thank you, Hannah, and also for highlighting the resources available on your website in terms of for families, and also the GTC as well in terms of resources. And we can highlight that on our website as well for people to follow afterwards. So if you didn't grab down the link, don't worry, we'll post it there. So you can easily access that, because there's a couple of questions about from the participants about community as well. Do you mind if I just have the slides up just for the last couple of points, because I'm aware of the time, and no, there's a couple of more questions in the chat, so I'm sorry if we haven't addressed that yet. We will get all of those questions from the Q&A panel, and we will be sure to answer the participants afterwards. So please don't worry if your question hasn't been addressed yet. We definitely will make sure that's responded to. Just closing up the webinar, just wanted to highlight a new education resource. So this is a new textbook that is out in regards to communication and swallowing management. So we'll also put some details there on our website, and in one of our upcoming newsletters, we'll have a review of that resource for you. So in terms of marking your calendars, we are doing 4 webinars per year. So our next one is Wednesday, May the 10th. So that is in Eastern Standard Time, so US time. So for here in Australia, and our colleagues around, that will be Thursday. So we will advertise that. So watch this space in terms of topic and speakers. That's the link to our website. So please visit the website to access all information about the webinars. The recording of this webinar will also be uploaded to that website, and details about the International Tracheostomy Symposium that Michael highlighted. So just to close out, I want to hand over to Michael to end our session.
Yeah, thanks so much, Amy. So I'd like to close with a big thank you, especially to all of those of you attending this session. There are about 300 plus diehards still on now. And one of the things that we know is that across the different time zones, we actually get a lot more views asynchronously than we do live. We actually had over 1,700 registrants for this particular session. Wearing my cap as the president of GTC, it makes me really proud to see the reach of this organization. I'd also like to call out our founder, Dr. David Robertson, who continues to watch and support us and is on this particular session. It's really a delight to have this phenomenal slate of panelists. Also, a little piece of trivia that might be interesting to some is that the International Tracheostomy Symposium actually predated the Global Tracheostomy Collaborative with their first symposia shortly before the GTC was founded. And that continues to be an inspiration as they co-sponsor our future events. So I hope to see all of you at our next upcoming webinar, as well as at our next International Tracheostomy Symposium, October 20th to 21st at Johns Hopkins in Baltimore. Thank you very much and have a wonderful evening.